much for coming today to hear all about bone health. I was really honored when they asked me to come and present this today and put all of this together. So, why bone health? Our bones do a lot for us, right? And we're going to learn a little bit about what our bones do for us and what we can do for them. They ask for so little in return, okay? This is not intended for any individual's medical advice. I'm hoping that you'll come away from this talk today as your own advocate. A little bit of information that you understand how to better be proactive in your care, okay? This is what we're going to talk about today. What is bone health? What do we mean by that? We're going to look a little bit at what the bones do and how they work so hard for us. We're also going to talk about osteoporosis. What is it and how do we treat it? How do cancer treatments affect our bone health and our bone density? Bone metastases. What is that and how do we treat it? And what can you do to keep your bones as healthy as possible? Okay. So I'm going to start, I thought it would be good to start out a little bit about what the bones do and what they look like. We have a skeleton, we all know that. We have an axial and appendicular skeleton. That's important for later in our talk. I have a method to my madness here. Our axial skeleton is the midline. It's the skull, the vertebrae, and the rib cage. The appendicular skeleton comes off the shoulder girdle, the pelvic girdle, so it includes those two, and your upper and lower limbs. The bones are living, growing tissues, mainly made of protein collagen and the mineral phosphorus. Keeps them flexible and strong. About 99% of our calcium is housed in our bones and our teeth, 1% in our serum or our blood. Bones have two layers. We have the cortical layer, okay, it's a denser layer, and then we have the trabecular layer, which is a little more spongy. We're made in a beautiful way that our bones do so much, but they're not so heavy that we can't move in gravity, okay? Oh, don't cheat and don't look at this. What do our bones do? Don't look. What do our bones do for us? A frame, yes. They protect. They protect all of those things, our organs that are so vital to our living. Our brain. Can you imagine if our spinal cord was just covered by the skin? We wouldn't be able to do anything. We would be prone to injury. Protects our lungs, our heart, right? It also supports us. Our bones are a place where our muscles attach or nerves attach, and we have purposeful movement. We can grab, we can reach, we can move, we can run. We're beautifully fluid in that way because of our bones. They store minerals such as calcium and phosphorus. We know calcium's good for our bones, but we need calcium for every other function in our body, our muscle function, nerve function. Calcium is essential. So our bones house that calcium so that other functions can occur. They also produce red cell, or blood. That's where we have our hematopoietic stem cells. That's in the red bone marrow. And any of you who have gone through therapy, you know that as clinicians, we want to know your CBC with diff. I always joked that we were vampires and don't let your family members get anywhere near my phlebotomist, they might get your blood too. We want to see it, so we see how you're tolerating your treatment, right? If you can continue treatment. So our bones are where we're making all of those stem cell lines. So we're making our red cells there. What do our red cells do? Carry oxygen. And we make our white cells, our B cells, our T cells. What do they do?
Fight infection.
Fight infection, yes. And platelets, what do? Your providers did great. They educated you well. Yes, they clot our blood. So if you came in and your platelet count was way too low, we may have said, hey, come back next week, and we'll start therapy then. It also stores and releases fat in the yellow marrow. As we get older, our yellow marrow becomes more prominent than our red marrow. So it's just kind of a little aside for you to know. Any questions? So see all the things that our bones do for us, and you'll find out soon they're not asking for a whole lot in return, and we can certainly give that back to them. We'll talk about that in a little bit. So as I said, bones are living, growing tissues. They're not stagnant. When I was young, I always pictured them as just bones, you know, they don't really do anything. They just hold me up, right? And then went on and played. You don't really think about bones at all. But they're constantly remodeling themselves. And we'll get into what that bone density looks like over the lifespan. But these are all of the components that are involved in bone remodeling. And it's really a balance of osteoclastic and osteoblastic activity. So osteoclasts take away or destroy old bone, so it makes way for the osteoblasts to reform the bone. So osteoclasts resorb and the osteoblasts reform. And I always get it mixed up in my head, and I have to think about it for a minute, because blast in my mind is like, you know, dynamite, you blast, it's going to destroy. It's not. It's the other way around. And then we also have osteocytes and the bone lining cells that all kind of are a part of this very important process of keeping our bones at equilibrium. Our body needs to be at equilibrium in all its functions, and the bones are not an exception. Okay? This is really important to understand when we go forward, when we talk about treatments for osteoporosis and bone metastasis. Okay, so bone density. We all have bones, men too, right? So bone density changes over our lifetime. When we're younger, the osteoblastic activity supersedes the osteoclastic activity. We are growing bone more than we're resorbing bone, because we're growing, we're getting our bones strong as we're younger. And what we do in our younger days is really important for our older years. So all that play is very important, right? All that milk that we drank. And then we have our peak bone mass anywhere between 20 and 30. You know, a lot of the literature I read was kind of that range. And then we start to have a decline right here. And why do you think that is? And that menopause. What is it about menopause that causes our bones to lose some density? Yes, ma'am. Lack of estrogen. Now, you see, with men, there's a decline in bone density as well as they get older, but it's not as precipitous. But men do go through an aging process where they start to have less hormone available as well. Okay?
And buy expensive cars.
And buy expensive cars, and hopefully don't find a girlfriend, right? So how do we measure that bone density? I'm sure many of you have done these. We measure by a DEXA scan. A DEXA scan is a low-dose X-ray, right? And it's monitoring your risk for fracture at baseline, and then it's monitoring subsequent scans for how your treatment's working, or monitoring just kind of your progress, depending on what your DEXA scan results came back the first time. They usually look at the lumbar spine and the hip, the femoral neck. So if you think about your pathophysiology from forever ago, you have your femur, you have the little neck, attaches in your hip. They're looking at that, okay? When these DEXA scans come back, oh, whoops. Wait a minute. I'm going to skip ahead because this is what I want, and we'll go back. When your DEXA scans come back, usually I would see a picture of that femoral neck and a fancy picture of the lumbar spine, and it would have a bunch of numbers. Really what we're looking at is it's a comparison, your score. It's almost like a report card for your bones, and your score is telling us what does your bone look like compared to somebody who has normal bone density. And then you're ranked, right? So if you have a -1 to a +2, now -1 is kind of pushing into osteopenia, so I hesitate. So thinking like from -1 to a +2, you're normal, you're good. If you're in the range of -1 to about a -2.4, it's osteopenia. What's osteopenia?
Osteoporosis.
Yeah. Very good. So osteopenia, if a patient came in and they had osteopenia, now caveat here, a lot of times when I treated osteoporosis in an oncology clinic, it's because a primary care physician sent them to me because they didn't have IV workup in their offices, and they wanted us to do that for them. But we still did the full exam and counseling and that kind of thing. But if somebody came back with osteopenia, usually the recommendation is, hey, let's start supplementing our vitamin D and our calcium, and then let's get some exercise, make sure we're doing some weight-bearing exercise. Yes? Then if you're a negative 2.5, the conversation changes a little bit, and we get more into what we can do to help what it is you're already doing at home. Okay?
By the time you're in osteoporosis, is it too late to do the vitamin D?
Nope. That's a great question. You want to keep doing that.
So you would do that plus more.
Mm-hmm. And we'll talk about bisphosphonate therapy that we do, and there's several ways to treat osteoporosis to supplant what you're doing as a person at home, but it's important that you keep doing those things to support what we're doing for you. Does that make sense? Yeah. Mm-hmm. They checked your blood work for osteoporosis?
For my blood work, for my bone density.
Unless there's a new way to check that, I'm not aware, unless they were looking at your serum calcium. But if you feel like it's something that you want to pursue and have, if you've not ever had a DEXA scan, it would be something to.
That was the only thing that they did after everything that I've been through this last year.
Right, right. Well, and this is why that we're having this talk today, so that you can feel be an advocate and say, hey, is this something we should be considering, and kind of bring it to their attention. Nothing wrong with that. Yeah.
At what age should a woman have the DEXA scan done?
That's up to your primary care physician, but usually when you're starting to hit menopause, I would think they would start looking at that.
I've been in menopause for 12 years, and
So-
I'm 55, and they've never suggested it.
So
I have bone cancer too.
it wouldn't hurt to, and again, I'm not going to make individual recommendations, but it wouldn't hurt to bring that up to your physician and say, hey, is this something that you recommend that I do?
Could you repeat the questions? It's hard to hear their question, but you have an answer and we don't know what they asked.
One lady asked, hey, I've been through all this therapy and they've only checked my blood, they haven't done a DEXA scan. Is that something we should be doing? And again, I encouraged her to go to her physician and talk to them a little bit about that. We all have bones, and especially after you've been through therapy, which can we'll talk about that more, facilitate more of a bone thinning. It wouldn't hurt to talk to your primary care. And another one said, I've been in menopause for a while. Should I have had a DEXA scan? So those are all questions certainly to ask your primary care or your oncologist. Yes.
I was told that for bone density test, the time period's now been extended from every 2 years to every 3 years. Have you heard that?
I have not heard that. I still saw every 2 years in literature, and that's usually what I've done. But again, talk to is that your physician who's told you that?
Both the oncologist and primary care nurse.
Okay. Okay, so that may have been a change. Yeah.
What was the question?
That she has heard that DEXA scan review should be every 3 years now rather than every 2. I know that when I was in clinical practice, I would see more of on a 2-year basis, but I'm not going to question individually what your physician. It could be an insurance thing. Yes, ma'am.
Is there any solid reason why a doctor would say you should not have one?
Not that I can think of.
Okay, so
Not that I can think of. Now, I mean, honestly, if you're getting treated for oncology, like an oncologic issue, if you have cancer, we're really focused on your cancer, right? So there's nothing wrong with saying, hey, do we want to check my bones out? There's not a thing wrong with that. Oh, wait, I want to go back because my slides got switched somehow. That was my fault. Okay, so what is osteoporosis? Osteoporosis means porous disease, right? Porous bone, I'm sorry. And it's sometimes called the silent disease because your bones are thinning and we're not really even aware. You don't feel that. It's characterized by a lone bone mass, like we talked about with those scores. And it weakens your bone and increases your risk for fracture. Now, osteoporosis is very treatable but not curable. We can reverse some of those effects, but it's not a curable disease process. It's pretty prevalent in America. About 10 million Americans have osteoporosis, another 44 million have lower bone density, which places them at increased risk. And then more prevalent in men than women, in women and the men, with a risk of breaking their bone in their lifetime. And this, I thought this was interesting. About 24% of patients who have a hip fracture past age 50 have a higher mortality. Yes?
Osteopenia is sort of is like pre-osteoporosis, and so is this all just normal living whether you have cancer or not?
Mhm.
And with the osteopenia, if they go, well, that's normal for your age,
Mhm.
how slow a process is that? I mean, are you naturally going to go from osteopenia to osteoporosis, or can you prevent?
Well, we're hoping that with increased exercise and calcium and vitamin D supplementation that we can keep you kind of at baseline and not continue to worsen. But whether you will or you won't is per the individual. But great question. Yes, we're going through osteoporosis first. This is outside of cancer, okay? Osteoporosis can happen to anybody. Well, cancer can happen to anybody, but osteoporosis is kind of a risk as our lifetime moves forward and we're going through menopause, right? So we have more of a risk with the loss of estrogen. And then, as some of you are aware, that if we block even your estrogen even further, we're going to have more of a decline in that bone density with treating cancers. Oh. All right, what are your risk factors? So as I get older in my life, I put things in the fixable and unfixable bucket. And I love it when things fit in the fixable bucket. So that's kind of how you look at clinical practice. Is it controllable or uncontrollable? What are the things that we can do, and what are the things we don't have control over? So uncontrollable risk factors are age, going through menopause, being a female, family history, and ethnicity. White and Asian women are more prone to osteoporosis, especially those of slight build, are more prone to osteoporosis than those of other ethnicities. But just because you're not white or Asian doesn't mean that you're not at risk, right? You have bones. And then things that are controllable, things that you can do for your bones, and we'll get into this a little bit more. You want a diet that's not low in calcium. You want a good, healthy diet with calcium, fruits and vegetables, smoking cessation, and not having excessive alcohol use or sedentary lifestyle. All of those things put you at risk. Yeah.
When you say weight-bearing exercise, what is your definition of weight-bearing?
Love that question. And we're going to get into it, but I'm going to answer it right here while we're here, but we'll get into it again. Weight-bearing is anything that puts you in gravity, right? So swimming is not weight-bearing, but if you're walking or yoga or even lifting weights a little bit, if you feel empowered to do that, those are all considered weight-bearing exercise.
So you don't need heavy weights.
You can do weights. It would be helpful to do weights, but if you're doing something like walking, you're in gravity, that's weight-bearing. Because your bones remodel when they have damage done to them, like when you're in gravity and they have this, like maybe little microfractures or whatever, and that's not something that's detrimental. It's just your body's in gravity and they go to rebuild that bone. Weight-bearing exercise helps that process continue. Okay. Great question. This is what your bones look like if you have osteoporosis versus normal. Do you get it now? Yeah. Those spaces are not supporting anything, right? And the beauty, we're seeing less and less, and when we get into bone metastases, we'll see less and less. We see less and less pathologic fractures because of the therapies that we have. We have better understanding of how to kind of keep these bones strong with those bisphosphonates or monoclonal antibodies that we have out there, and we'll get into it in a minute. Oh, here we are. Okay, so these are treatments for osteoporosis. This is not treatments for bone metastases. We have bisphosphonates that work to slow down that overzealous osteoclast, okay? That's basically what they do. And you've seen the Blythe Danner commercials and the Sally Field commercials just traipsing through the forest. But we have, I know, I'm like, who does that? And then meet somebody with balloons, like I'm just like, it's crazy. Beniva and Actonel are orals that we take, and then we have, and Fosamax as well, and then we have Reclast, which is a once yearly infusion of a bisphosphonate. There's a new one, and that's Prolia, that is a monoclonal antibody, and it's a shot. And then you have, this is an interesting class of medications right here, the estrogen agonist-antagonist. Avista is used in those with thinning bone. I didn't see that a whole ton. Again, I wasn't in primary care practice, but the estrogen agonist-antagonist, what they do is they are protective of the estrogen that's working to the bone, but go after the estrogen that's going for the reproductive organs. So, tamoxifen. Yes, ma'am. Yeah, so with the bisphosphonates and the monoclonal antibody Prolia, we have risk of something called osteonecrosis of the jaw, which is, I just kind of wanted to point that out. There's other side effects for sure, and this is by no means an exhaustive, in-depth look at these drugs. But osteonecrosis of the jaw is why it's very rare, but it can happen, and it's why your provider will be like, have you had any recent dental work? Have you seen your dentist in a while? Let me do a dental exam and look in your mouth, make sure, do you have plans for a root canal, those kinds of things, and we may push it off. From what I understand, it was post-marketing they started seeing this problem, and it took a while to realize, hey, this is the bisphosphonate therapy that's doing it. So we're aware, and we monitor people. If you do develop osteocrosis of the jaw, I think I can think of one person, while on bisphosphonate therapy, then you won't get that drug anymore. It's just where it's where the tissue gets damaged in the jaw. It can heal. Yeah, but it'll heal. It just takes a while. And it's very painful. But once somebody develops that, they can't have bisphosphonate therapy anymore. Okay, so yes.
Is this, sorry I came in late, can that come after, like years after something happened after treatment, or is it during?
It's usually during treatment, and I'd have to look it up to see if there's cases where people all of a sudden, like 5 years, I have to look that. I don't have the answer to that question right off the top of my head. That's a great question. Yes, ma'am.
I would share with you that I did have to have a dental procedure.
Uh-huh.
I had been off of all the medication, and I had been on the Prolia and Reclast when I was taking all my medication. The first surgeon I went to refused to touch me because I gave my Beniva and not Beniva, but Reclast and Prolia. I then went to another surgeon who specialized in reconstruction of the jaw, just in case something happened. And he agreed to do the surgery, but I needed to be off of everything for a minimum of 18 months.
Wow.
So I did go on and have the procedure, and I did not have any repercussions after that.
Oh, good.
But you just need to be aware of that.
Mm-hmm.
And my oncologist had told me not to take either of those drugs more than 5 years.
Mm-hmm.
Well, now since I've had a recurrence, they're wanting me to go back on
Mhm.
one of the osteo drugs.
Mm-hmm.
And I'm going, but wait a minute, you told me not to do it again because I had already been on it for 5 years.
Mm-hmm.
So now I'm kind of holding pattern trying to determine what to do.
Mm-hmm. Well, in the mean,
A year ago, they told me I'd only have to take it for 5 years.
Mhm.
And then when I went for my checkup recently, they told me I'm gonna have to take it for the rest of my life.
oh, that's a new one. So what I could find, I find that that's kind of provider specific. The 5 years is the general cutoff. really what I could tell from when I was doing research for this is they're trying to figure out, is there a stopping point? Like, do we get to a certain point and we can stop the drug? Now, I don't know if it's from what I can tell, the longer you're on these drugs, maybe more of a risk of these things happening. Like they've seen thigh bone fracture as well. So that's just kind of the art of medicine being applied to the science, right? So just everything's very individual in how everybody doesn't fit in that same bucket. But a lot of what we use these drugs for is to see, can we stave off a fracture? We want to do fracture prevention, and we want to keep those bones at baseline for as long as we can. But that's the great debate with any oral drug. How long do we leave these people on these orals? Do we leave them on it just because we can? So a lot of studies that I'm seeing now coming out of the oncology world is limited time on orals. Can we stop it after 2 years? Can we stop it after 1 year? Can we stop it after 5 years? The big debate with tamoxifen, how long do you stay on it? How long do you stay on the AI? So that's a great question and a great answer. I mean, that's the big question, and that's where you go to your provider and have those conversations for sure. Okay, so some cancer patients come to me and they're already being treated for osteoporosis. I know in our clinic, anybody who walked in the door, we're doing a past medical history, looking at all your diseases, all the chronic illnesses, and all the medicine, so medicine reconciliation. Some people receive cancer treatments that may increase your risk of developing osteoporosis or further worsening your bone density. Some patients have cancers that started in their bone, and that's not bone metastasis. That's not breast cancer that's now in your bone. That's like a multiple myeloma. Or some patients have cancers that start in their, let's say in their breast, and it ends up in their bone, and so they have bony metastasis. Okay? We treat those, we'll get into that in a minute. So again, this is where we're empowering you. Make sure that you're having the conversations with your physicians and that everybody's on board. Generally, when we got our patients, they came out of primary care because that's where something was found. But there's nothing wrong with making sure that those two entities are talking, and I saw a lot of my patients carrying their little notebooks with all their stuff, and I can't tell you how many times there's something in that notebook. I was like, I needed that. That's great. So that's basically what I think this slide does. So make sure that you're communicating. So bone loss that occurs with cancer therapy, that could be chemotherapy, possibly putting somebody into menopause. That can be hormone blockade, like an aromatase inhibitor. That could be surgery, like an oophorectomy or a parathyroidectomy. Radiation, chronic steroid use, any of those can quickly, more rapidly result in a postmenopausal or in a bone loss than the person who's not going through those therapies. So cancer treatments can affect our bones as well.
If my chemotherapy put me, I wasn't in menopause before chemo. I started chemo and now I'm in menopause. Does that mean my body's not making estrogen anymore? I'm still taking an estrogen blocker because I'm taking tamoxifen, and from what I understand, even when you stop producing estrogen because of menopause, sorry, I have to think of
That's
words,
okay.
that there's still estrogen in your body.
Mhm.
It's stored in your fat
Mhm.
cells, and that
Mhm.
you still are going to have it in there forever,
Mm-hmm.
right?
Mm-hmm.
So the estrogen blocker I'm taking is just blocking that. It's fighting less estrogen now because I'm in menopause,
Mm-hmm.
right?
Mm-hmm.
Okay, so, and because it is, tamoxifan's an agonist and an antagonist for
Mhm.
estrogen, I guess what I'm saying is,
Your bones are being protected.
okay, my
Right.
bones are being protected.
We're not worried about bone loss with tamoxifen as we are with the aromatase inhibitors.
Okay, so it's still being protected. Okay. Sorry, that was very confusing.
No, you did very well. And then again, it's a question too, do doesn't hurt to supplement calcium and vitamin D unless there's some reason you should not be, and getting exercise. Those things are all healthy for our bones. And again, men are at risk too. So patients undergoing treatment for prostate cancer, and we're blocking their hormones as well, they have risk for thinning, or who are on chronic steroids. And that's not just like episodically we're giving you a steroid for this or that. It's like daily oral steroid. These patients have more of a risk for thinning bone. I kept this slide. Oh, yes, ma'am. I didn't see any statistics. That's a fantastic question. That's something I'd have to go back and look at. I don't know that there are any studies that looked at that on a broad scale. That's a great question. I kept this slide in here. I almost didn't, but I thought it was important because some chemotherapies, I didn't see hypocalcemia a lot, but hypocalcemia means your serum calcium is low. Remember I said 99% of your calcium's in your bones and about 1% in your blood. So if whenever I went to treat somebody with reclass for osteoporosis, this had nothing to do with their cancer, and I would look at their serum, they had to come in with their serum calcium, and it had to be a certain level. So you have to make sure that whenever somebody's giving you a bisphosphonate or you're taking these drugs, they are making sure that your serum calcium is acceptable before we continue, right? We need that calcium to build the bone, and we don't want to drop even lower. Okay, so we've gone from what the bones do for us. They're quite remarkable. We've gone into osteoporosis and what that is, okay? We've talked about how cancer therapies can kind of facilitate bone loss. Some of them can. And now we're talking about bone metastases. It's a lot in one deck, right? And bone metastases, we could talk about like a whole other conversation. But what are bone metastases? And I'm not saying that in a way to question your knowledge. I just had so many patients that would come in and say, I have bone cancer and I have breast cancer. Well, most likely it's cancer that's gone from your bone, your breast to your bone. So bone metastases, if you'll bear with me for a minute, when people are diagnosed, they're staged, stage 1, 2, 3, or 4. And stage 1, it's still there in one spot. Stage 2, maybe it's grown a little bit more. Stage 3, it's more extensive. Stage 4 is it's metastasized. The ones that most likely metastasize to the bone are lung, breast, and prostate. That's not exhaustive, but those are the most prevalent ones. And we treat them pretty well now because we have these bisphosphonates and we can prevent pathologic fracture, and we have all sorts of therapies. Let's see. Bone metastases are not, like I said, are not the same thing as cancer that starts in the bone. Okay. Okay, that's that word, axial. What was the axial skeleton? It's a really quick quiz.
Your skull, your lungs, your rib cage, your vertebrae.
Yep.
Good job.
So that's where we primarily will see the bone. Isn't that awesome? She gets an A. I wish I had like a gold star. There's two types of bone metastases. You have osteolytic, where they're destroying new bone, or an osteoblastic, which is dysfunctional formation of new bone. So the bone's getting thicker and more rigid and not as flexible as it needs to be. Or you can have mixed. Breast cancer patients can have mixed. I don't know that we look at, hey, this is an osteolytic bone met versus an osteoblastic bone met. We just treat the bone metastasis. This process can cause all sorts of deals, right? Bone pain, bone fracture, a life-threatening electrolyte imbalance. I can think of hypercalcemia, which we can touch on a little bit, and then can compress nerves, causing pain and weakness. So if somebody has like a spinal cord compression from their bone metastasis, that's what we consider an oncologic emergency, and that person gets radiation and whatever is decided on immediately, so they don't lose function. Bone bone metastases are not curable, but we palliate them and the care is supportive only. It's a stage 4. So when I was building this slide, there's a lot of avenues and a lot of weeds we can dig through, excuse me, how to treat bone metastasis, and I thought this was the best way to present it because each situation is so individual. But there's several things. It's funny, as clinicians, you don't realize how algorithmically you're thinking when you look at a patient. You're just like, okay, you have this, and if this happens, then we go over here. If this happens, we go over here. If yes, then no. And you don't realize how much of that you're doing until you're trying to put down a slide. So you're looking at, is the MET localized? Is it widespread? Do we have METs outside the bone and in the viscera, which is organs like lung, liver? What kind of cancer is it? What features does it have? Is it estrogen positive, like in the breast cancer? What kind of therapies have we already been through that we're no longer responding to? We don't want to give those because the cancer's already gotten smart, right? And then symptoms and performance status. So when we're treating bone mets, we go after the symptoms to palliate them so you can live your best life, right? And supportive care in that way. And then we also look at your performance status. And performance status is the way that we grade you when we assess you when you come in the door. It's called ECOG. And we look at how well you're functioning, how mobile you are, those kinds of things. And it gives us an idea of what you can tolerate. Can we throw this kitchen sink at you? Or do we just need to squirt you with some water? Like, it just depends, because we don't, just because the doctor I worked with would always say, just because we can doesn't mean we should, right? So it's very individual and tailored in what we're looking at. So that's why I put at the bottom, available treatments are supportive only with the goal to palliate pain, slow growth, prevent fractures, and fix an imbalance.
If your cancer, let's say for example, you started with breast cancer and then it did metastasize to the bone, would it be the same type of cancer, or is there a chance that it can be different? It's going to be the exact same type you had
cancer.
before because that's where it originated.
Cancer, this is a whole other conversation, and it kind of gets me going because cancer is really smart, right? It kind of has this pathway that it's our own body, but it's misbehaving and it's over proliferating because it's not listening to whatever signal to turn off and die, right? So it's doing its thing and it's overgrowing, and then at some point it starts to grow its own vascular system, and it's a very dysfunctional vascular system, and then it's able to go other places and plant itself where it finds nourishment. And that's why we have these therapies to hopefully keep that from happening, but cancer can do that. So anyway, that's I aside on that, but it's amazing how smart it can be. All right, we talked about how good your bones are to you. They do a lot for you to keep your body in balance, to provide you with what you need. What can you do to give back? And it basically comes down to nutrition and exercise and lifestyle modifications. So nutrition, a well-balanced diet, rich in calcium, foods that contain calcium and vitamin D, all sorts of resources out there on the internet that tell us, what foods have a lot of calcium in them. And then recommended daily calcium. I got this off of NIH Medline Plus. 1,000 milligrams a day for those 19 to 50. I don't know how many 19-year-olds are thinking about their calcium.
Oh, right.
Really. I know my 20-year-old isn't. And then 1,200 milligrams a day for those 51 and older. Now, I always understood that we can only absorb 500 milligrams of calcium at a time, so we're excreting the rest. So if your doctor wants you to do 1,200 milligrams a day, that's telling me you're taking calcium, that 600 3 times a day, right? And then, or they come in 600 milligram tablets or capsules usually. Well, wait, no, that would be right. You would take it twice a day. I'm sorry, ignore me.
So you spread it out so it can absorb a little bit at a time.
Yeah, well, I'm calculating things wrong. I don't know what I was thinking in my head. 1,200 is 2, twice a day.
Don't take
Yeah.
it all at one time because
Oh, you can.
Oh, okay.
It just will excrete out the rest.
Oh,
But that's true. Now I
Yes, that's
backtrack
right.
again. If you're only taking 500 in a day, if you're only able to absorb 500 milligrams of it or so, and then we're given 600 milligram tablets and you're excreting out the rest, then yeah, you might 3 times a day is usually what's recommended. But who's going to remember? Yeah. Yeah, but I'm thinking if you're taking it twice a day and then you're supplementing with calcium in your diet, you're probably getting good there. Vitamin D, yes.
So I've been taking 1,200 at one time. So
Spread it out,
So it's like 600 or so that's going away.
probably. Yeah. Probably.
Doing that for years.
But hey, you're getting your
Well,
calcium
see,
though.
at first, I was only taking one because the bottle said, I didn't realize until I read the back of it, you had to take 2 to get 1,200 milligrams.
Take 1 twice a day if you can think of it. I'm just happy you're taking your calcium. There's so many. I mean, I am a nurse practitioner, and I don't think about my calcium like I should until I do stuff like this. I'm like, I really should take that. So, yay that you're taking it every day. But if you can remember, split it up. Yeah.
Do you ever recommend people take vitamin K, like M7 and M4, to try to direct the calcium where you want it to go? Like if you're
I haven't. That's more of like a dietitian kind of knowledge base there. So, is that something in your background that you know about?
yeah, well, as somebody who's had breast cancer, but I'm also a PT and a health and wellness stuff, so I have some information, but
I haven't heard that, and we have to be careful to supplement vitamin K for those who are
Right.
on Coumadin. So I haven't done that. But that's
vitamin
good.
D, like you probably should have monitored
Yeah.
blood. I mean, yeah, the vitamin D.
Well, and you may need more than 600. Like your primary care doctor. I mean, being low in vitamin D. What do we do every day that makes us low in vitamin D? Or we should be doing? Yeah, and we put on what when we go out there? So the only way we're making vitamin D is in the sun, but we want to protect our skin. So you've got to get that vitamin D somehow. And being low in vitamin D can affect nerve function and all sorts of things. So your primary care doc should probably be looking at that, or if he's not, maybe ask him to. I don't know. But generally the recommendation is 600 IUs a day. And I think that's kind of what's already in the, if you're doing calcium plus D, that's probably what's in there. Okay. And then daily exercise. Here's a sticky wicket, 30 minutes a day. That's funny. Who does that? Nobody does that. Hey, better than what I'm doing half the time. I'm like, I really should go walk. That's probably about my 30 minutes a day. But 30 minutes of daily weight bearing. Now, I know if you're going through therapy, you feel really terrible and you don't want to exercise. But I found that, fatigue is a big complaint with therapy. Get to your question in a second. Big complaint with therapy, but I find if patients were more mobile and had some exercise in their day, the fatigue was a little better. But do what fits you. Again, as I get older, I realize I'm not training for a marathon. I'm just not doing it. I didn't do it when I was 20. I'm not going to do it. The only time you're going to see me running is out of a burning building. That's it. That's it. But I walk. I love to walk, or ride a bike, or do yoga, whatever inspires me. So that's what you find for you, and build to that 30 minutes a day. If you're not exercising now, then don't expect that you're going to do that 30 minutes a day and be able to tolerate that. I know that I was traveling a lot for my nurse educator job, and I was not exercising. When I got back into it, whew, wow, I lost a lot. What was your question?
Oh, 2 things. On the vitamin, which one is it? The calcium.
Mm-hmm.
Are there time release ones? Have I seen that, or am I thinking of something else?
I haven't seen that. I mean, I know about Oscal, and then, that's a good one, but there might be. It'd be something to ask your pharmacist.
Okay, and then when you talk about calcium and vitamin D, I read something that said magnesium's kind of making its way in there.
Mm-hmm. And be careful with supplementing that. I mean, if you have high magnesium, that would be something that if you are low in magnesium, that's something that your physician will find in blood work if they're looking for that for some reason, like you're having symptoms of that, and then maybe tell you to supplement your magnesium. I'd have to look at magnesium to see if it's water soluble or fat soluble, something that you store rather than excrete. So, great question. I didn't think to look that one up before I came. Yep.
Question about vitamin D. Should you spread that out throughout the day, like C and calcium, can you take it all? I take more than 600 milligrams, so.
I think you can take it all at one time. I've not ever been told or learned to counsel somebody to split that up. Because people get shots of vitamin D, that's all at one time. But of course that delivers differently. When you get a shot, it's going right to your blood versus when you take it by mouth, it goes through your stomach, then first passes the liver. Anyway. But it's just absorbed differently. But yeah, you get it all at once in that shot, so.
I read a long time ago that your vitamins at night, because while you're sleeping is when your body is rejuvenating itself, and that's when it's gonna go looking for the vitamins. I don't know if there's any proof for that or not.
Nothing to hurt, but if it's something that,
makes sense.
if that tags you to think I need to take my vitamin today, and that's when you take it, perfect. That's how it makes sense to me. Absolutely. All right, we talked about all this already.
Question.
Mm-hmm.
So, I realize sometimes it's been, they take that and they put it up
Mm-hmm.
for a couple days.
I wouldn't double up if that's what you're
Well,
gonna.
no, my question is, I worry like I set myself up for failure,
I don't think so. I mean, you're on those drugs for it's hard to remember. I'm sure there's days that you've forgotten. Maybe think of better ways to remember.
I just wish Relaxa would bring it to me.
We need to invent that.
Please, bring.
It's hard to remember an oral every day for years and years and years. So maybe put a sticky on your mirror where you brush your teeth. Take your medicine today. I don't know. I would be bad at remembering too. All right. We know all this about exercise, right? We know all that. Don't smoke. Okay, here's the public service announcement. Don't smoke, don't drink. Talk to your doctor about whether you need a bone mineral density or DEXA scan. And from there, talk to him about, or her, or your advanced practice provider about what we should be doing. Okay. That's it. Any other burning questions? Thank you. Thanks. Okay. Yes, ma'am. I love it. I've actually taken people's phones and done that for them. Oh.
I have one of those things where it has a flip off so you get for a whole week.
Mm-hmm.
So you sit there and,
Yeah.
I cannot take it, I take a medicine first thing in the morning, I cannot take anybody for 4 hours.
Well, it's good that you know that.
So I've always been taking all my vitamins stuff with supper. And now you're telling me I have to take some at lunch too.
Not necessarily. That's something to talk to your doctor about how much calcium you need and how you spread it out.
I'm already low calcium. That's what they're checking my blood work every 3 months for that.
Oh, wow. Okay. Yeah. Make sure you're taking that calcium for sure. And eating good food, like that salad.
Between sugar and bone density, I mean, I know that sugar's so hard. or addictive.
There's a lot of stuff out there about sugar and facilitating cancer growth and all this. I don't even know that that's a true thing. I'd have to look and see if there's peer-reviewed studies looking at sugar and bone metastases and the effect.
There's been a whole lot of stuff on the internet and in magazines lately about, drinking milk versus almond milk or soy milk or whatever to get your calcium. I grew up being told milk is the best way to get your calcium. Is it still considered in the medical field like, yes, we should be drinking milk every day, a glass of milk every day, or is milk falling out of favor, or is that just?
So I think there's been a push against milk. Poor milk's getting a bad rap because it has a lot more sugar than the nut milks do. But if you look at almonds, they actually have more calcium than regular cow milk does. So those people who are kind of like super aware of their diet and getting extra sugar, they may not be drinking the milk, or lactose intolerant or whatever, but milk is a perfectly fine thing to drink. Almond milk amazingly has some great calcium in there. Almonds do too. Mm-hmm. Mm-hmm. The phytoestrogens. Mm-hmm. The phytoestrogens, yeah.
People coming at me strong about soy and strongly against
You know, I'm going to have to totally do research on that. I can't say that that was something I talked to my patients about regularly with soy and avoiding things. I was just happy they were eating when they're getting their therapy and keeping their strength up, and that was a lot of our conversation of getting high fat, protein dense, caloric intake, not high fat, but good fat kind of caloric dense foods. If I needed further help in the nutrition realm, that's where I reached out to my nutrition colleagues.